The name of the talk, Addressing the Affordability Crisis in a Reform World, may be misleading, at least it may be misleading in regards to what I'm going to talk about. I'm not going to really mention the American Health Care Act. I don't go into any kind of detail. I'm sure other speakers are doing that, and I know quite a bit about it, probably more than I'd like. But that said, I really am going to talk about the affordability crisis in this country, and particularly in California, between now and 2014, and what we need to do to get a handle on costs. And this will run through 2014 as well. So with that, I want to spend just a moment talking about the environment, and I will show you slides that you've probably seen about 100 times about what the kind of affordability crisis is that we're faced in America and here in California. But just to reinforce the point, there are some things that we can do about it, and that's good news. In some cases, we are doing some things about it, and we're getting real success rates. And it's far too little to really address the size of the issue. And healthcare reform or not, regardless of what the court does, regardless of whether Obama's reelected, this issue is still going to be a central theme to American healthcare until we get these costs closer to CPI. And I think time is running out. I don't think it's a matter of waiting till 2014 and then all of a sudden the solutions will be here. In fact, in many cases, 2014 may be a more difficult couple of years for the system as we adjust to the new comprehensive benefits and the new rules. And while we very much support the access that's created by the reform bill, we do have concerns about some areas in which costs are driven up, at least initially, by the more comprehensive benefits. Just a quick commercial on Blue Shield of California. We've been around a bit since 1939. We were founded by the CMA. They were, in fact, their board of governors was the board of directors for Blue Shield of California in 1939 till 1973. At that time, we converted to a 501c4. We are not a charitable organization. We're a federal tax-paying entity, and nonetheless, we are not for profit. We have about 3.4 million members, which means that we're the third largest in the state, behind Anthem, Blue Cross, and Kaiser. About $10 billion in revenue. And one of the things that certainly our organization is known for, perhaps I'm known for, is that in 2003, the organization came out in full support of a universal coverage plan in California, although we felt that it was an appropriate formula for the U.S. as well, and believed that we could actually get basic health care benefits for every man, woman, and child in California. We felt that it would take about $10 billion, and we suggested that there was a way to get there. That was a time in which we had at least some of the surpluses left in the budget. And we worked very hard to achieve that. We worked with Governor Schwarzenegger in 2007 on his plan. Obviously, none of those efforts prevailed. And again, I think we see a lot of what we were interested in, namely guaranteed issue coverage, no discrimination for health care status, and a number of the other elements of the national bill that reflects our point of view about what is right, namely that health care is a right and that, in fact, everyone, including the 7 million people in California who don't have insurance, ought to have it and ought to be either subsidized if they can't afford it and ought to be mandated to buy it if they can. So with that, I could leave this chart up and really be done. I mean, this is the fact of the matter, which is that over the last decade, our premiums have gone up about 135%. If you just look at inflation, it's about 25% over that same period of time. And that gap tells the whole story. People in the workforce and employers are looking at that green line and saying that's the level at which Everything else is going up, if I'm an employer, my wages, my cost of goods. In fact, in many areas, my costs are going down if I look at information technology. And here I have healthcare eating up a larger and larger piece of the pie. Approaching $3 trillion are healthcare expenses in the United States. And in fact, if you were to extend this line, even today it's very high, but if you were to extend this another 10 years, the cost of a healthcare, I'll call it a comprehensive package, it's not all that comprehensive, would be roughly about $40,000 or 50% of the adjusted gross income of the average American. So it's already moving between 15 and 20% for many people. And once it gets into that level of, and for employers, obviously, it's getting to be a higher and higher bill, and it's about 17% of our economy. This simply can't last, not because prices won't go up automatically, but I think we are headed to a place where if the Affordable Care Act and or some variation on that theme helps, and if we do things together, I think we can make a big dent in this, and I'll demonstrate how we've done that at Blue Shield. But the gap is so wide that given its trend, and we've had a couple of good years, primarily through no cause of our own. The utilization nationally has gone down. We think that's connected to the economy and probably some deferred care that will be coming back, but I wouldn't count on not seeing mid to single or to high single digits increases probably in 2 to 3 years as that lull subsides and finally people need the care that they've been deferring. Again, we know where the costs are coming from. The hospital costs are the primary driver. They've gone up over the last 10 years, about 13% on a compounded basis here in California, and that's been the biggest piece of increase. Pharmaceutical costs, this is just a profitability chart comparing the pharmaceutical companies from the United States and their margin vis-a-vis the margins of the Fortune 500. Now, there's nothing wrong with making 17% if that's what your shareholders demand and if you're providing that kind of value. What is wrong is that the cost of drugs in the United States are subsidizing the cost of drugs in other countries. And so from an equity standpoint, we are not getting that kind of value here in the United States. And that is, in fact, because there's price controls in other states. And it seems to me that the pharmaceutical companies really need to think long and hard about, in terms of being part of the solution, how they're going to help adjust that to a more equitable way of distribution and working both to get their costs down, but also to redistribute that in a more meaningful way so that the United States gets to take advantage of the really good work that drug companies do. And while I showed you that hospital costs had gone up, this is what we know is a major driver in why they have gone up. And we call it the cost shift. We know from the OSHPA data in our system that in our hospitals, obviously on the uninsured, they make next to nothing. For Medi-Cal, they make about 30% less than their cost, 20% less on Medicare. And they then charge us, and then we charge our customers, of course, about 35% margins is what they make on our business so that they can make at the end of the day about 3.8%. So it's not a function of them getting a compounded 13% profit increase. In fact, those underlying costs are eating that up, and the cost shift eats up even more. The net result is that private payers and individuals are making up for all of the underpayment that is coming from other sources. That will be helped by the reform bill. And indeed, that is one of the pieces that in our original proposal we said we had to stop. That in fact, whatever the value of a cost or a procedure, it ought to be the same within a government system as outside a government system if we were going to make rational decisions around the cost and value of individual procedures. Again, I said I wouldn't talk about federal reform, but I do think it's important that at least federal reform has shone the light on very important elements of the solutions that I think stand behind this. The first is accountable care organizations. Now, I don't know, this may be an audience of 75 to 100 people. We probably have 100 different definitions of what an accountable care organization. I will talk a little bit later about what it's been for Blue Shield and what it means, but I do think it, in fact, is a very meaningful way in which we can manage both quality and cost more effectively. Blue Shield, like many other health plans, are investing in value-based benefit designs. Again, lots of different definitions of that. I'll talk about our variation on that theme. The concept of patient-centered medical homes, which can be actually at the center of accountable care organizations, in which the primary care physician is really at the focus with the patient and really manages the care as a partner to the patient, using all of the resources of their team. Robbie Pearl is going to be speaking right after I'm done, and in fact, this is a concept that really Kaiser has perfected by using all of the resources of the team, coordinating care and using technology to ensure that everybody understands what has happened with the patient, where the patient is in the process, and make sure that as members of the team that they're doing their part. And certainly Robbie's far better positioned to tell you about how they do that. I think it is, in fact, some of those elements that we'll be bringing to the network-based systems to reduce cost. Pay per performance, my own view is if we could kill fee-for-service over the next decade, we would have all done a very good thing. Paying for piecework has turned out to be a disaster for American medicine. It has all of the wrong incentives. It certainly was, when it was first designed, understandable that people ought to be paid for their time and their effort, and there's nothing wrong with that. But we forgot about also putting some kind of premium on outcomes. And we think we ought to spend, not today, that's a whole other talk, about how we ought to adjust the mechanisms for payment to really incent the highest quality and lowest cost. I think, and this is still very much up for debate, but I do believe that wellness programs do work. We've had a wellness program in our company for the last 4 years. We're in fact just seeing the impact of it in a real way. So it is not for the faint of heart. It takes time, but I'll describe what we're doing, and there's other companies that are doing it and getting similar returns. But it is a big part of the picture. I started in this industry 30 years ago, which was a very long time ago. And I started as a member of a health maintenance organization. Well, the whole idea of health maintenance is the notion of prevention, and wellness is where it starts. And I think actually both consumer transparency and wellness is a big part of that. So that brings me to comparative effectiveness research. I sit on the IOM board for value and science-driven care, and there we look at all the things that are going on across the country in terms of looking at similar or the same kinds of therapies, procedures, and trying to determine what value in comparing both their effectiveness, their cost effectiveness, and of course many of these therapies are very exciting, in many cases also very expensive, and the question is, does that added expense add the same amount of value? And I think we're starting to get answers to those questions. We're a long way away from having all of healthcare understood on a scientific basis, but the pieces that we are getting to understand the underlying science of, we can make judgments based on whether one drug or another drug is more effective, and especially if it's less expensive and equally effective, we ought to take it to heart that that is what this system needs to get back to a more affordable basis for care. I want to talk about the private sector, and I want to look at 3 areas quickly that I think we should be working on with employers, with each other, if we're going to crack the nut of affordability. The first is working closely with employers in presenting rational options, both in terms of products and networks that can be more affordable. Up to this point, to a very great extent, with the exception of Kaiser, most of the health plans in California offer very similar products. We offer the same physicians, the same hospitals. If you have a large PPO network, you're going to find most of the same providers in those networks. Anthem Blue Cross and Blue Shield have the largest, but even Cigna and Aetna are going to have many of those same hospitals and physicians. So not a lot of differentiation there. And we think that there's an opportunity here to really drive costs by virtue of identifying, if you will, the best physicians, best meaning, most effective at driving lower cost outcomes at higher quality. Again, I will speak about incentives for health, and also an overall notion of how we drive efficiencies in the system that support equity. And by equity, I mean making sure that all of the things we're doing, the beneficiaries of all the things we are doing are not just people that can afford high-cost care, but actually do bleed into our social and public programs. And in fact, Blue Shield's foundation gives about $30 million a year to a variety of things, but one of the things we do is invest in the safety net and in trying to get the public clinics to, in fact, take advantage of many of the things that the private clinics are doing very effectively. Now, I can also tell you that some of the public clinics are more cost-effective at what they do than the private clinics. So it's a matter of finding those areas and supporting those areas where system reforms that really can drive efficiency and result in not just commercial members, but all members and all people in California getting care. I thought I would just start with the incentives around health. Safeway is known for the program they have there, and Steve Bird, if he talks next year at this, can tell you what they do. But he's very proud of what they've accomplished in terms of driving down costs. They do that through an HSA product and design and some very strong carrots and sticks in terms of how they work with their population. Johnson & Johnson, I would say, from my own point of view, is the very best in this area. They have a culture of health. They have had a long-standing culture of health. Their leadership is aligned around health. And Blue Shield of California is doing something similar. We have incentives, we pay financial incentives for people that get biometric screening. If they take the next step of getting a coach and working on those things in their biometrics that actually are, if you will, off normal, they get a health day off. And if they continue doing that throughout the year, they get a reduction in their out-of-pocket, and that can go down to zero. So we're giving them a lot of incentives, and we're just, as I said, starting to see the return on a reduction in our claims data. But it took about 3 years to see that. From a network standpoint, you've heard from Ann Boynton, or you will. She will probably talk more about the Accountable Care Organization that we built in Sacramento with CalPERS, Hill Physicians, and Catholic Healthcare West. It was really everybody pitching in and everyone taking risk. I'm not talking about global capitation going to providers. I'm talking about all of us equally at risk for all the services that were applied. So they had risk for our administrative services. We had risk for their healthcare services. On every line item, we took an element of risk. They took an element of risk. What we were able to achieve, and we guaranteed CalPERS we would do this, so it's good that we did achieve it, was a zero trend in the very first year of operation. We reduced readmissions by 15%, we reduced inpatient bed days by 15%, and we had customer satisfaction in the 90s. So it really was just one model of coordination, and while we did this in a sense with spreadsheets and not a sophisticated piece of technology, we're in the process of actually building technology that will support these kinds of models, and actually have given $20 million in grants for others across the state that are interested in getting involved in this to build infrastructure that would also make them effective in providing a similar kind of organization. Value-based network, our product is called Blue Groove. It essentially requires the employee to make one of three choices. I want to keep my large PPO, which they can do. They pay a great deal for that. And they essentially have about a 50% coinsurance, but they can keep their very large PPO. The second choice they can make is to enroll in a network which first requires them to get biometrics and screening assessments, and then secondly to do something about it. And what they do depends on what the company wants to put in place. The network is about 60% in terms of size, but it's an HMO network in effect. It's or an EPO network. It's a much smaller, more cost-effective network. And then particularly for those who are chronically ill, we have a very small number of very highly skilled physicians and hospital programs in which we allow people to enroll, in effect, authenticate the diagnosis, whether it's cancer or asthma. We focus on their chronic care management in and out of the home, and there's essentially no coinsurance on those products. That's one way to encourage people to do the right thing and to provide incentives for them to do the right thing. Transparency is the other piece. As I talked about comparative effectiveness research, what we know is that there are certain procedures, if we compare them, that cost vastly different sums of money, especially across the country, but we don't get any better outcome. Here in California, you can look at the very same procedure and see that, for example, in Marysville, if you get a bypass, it's roughly 5 times the state average. That kind of variation is not explained by unique circumstances. That is explained by unique negotiating circumstances. And likewise, vaginal delivery under C-section. Again, this is the function of a system that is not based on value, but a system that has been based on how much can I negotiate for my piecework, and likewise health plans pushing back and trying to reduce those costs. I think in the long term that is not going to be a very effective way for us to get health care costs down. But it is the system we use today, and it's the one that we're stuck with until we change it. The transparency bill that we supported, certainly not very popular with hospitals, but we thought it was important to shine light on at least our members' costs and to be able to tell them that if you're going to go to hospital XYZ, this is what a hip replacement will cost you, and if you go to hospital ABC, that very same hip replacement will cost you this. We think this gives the consumer informed choice. There may be unique circumstances why costs are different, and members will make decisions, and we see members make decisions based either on their physician advice or for other reasons to go to higher cost facilities for their procedure. But they've made an informed choice, and they know now that since they're often paying coinsurance in our PPO product, that they've made an informed choice and they understand what the ramifications of that are for their 20% of the bill. And we think that's the first step. We think actually open transparency, likewise for us. We believe that transparency for Blue Shield is as important as it is for hospitals and providers. We're in the position of being a not-for-profit. In essence, when we work with CalPERS, for example, our books are open. They have in their contract the opportunity to audit anything they want to audit at any time. We've capped our income at 2 cents on every dollar. This last year, we made that decision actually in August of 2010, but didn't implement it till the spring of last year. And what that means is we believe that we can achieve what the organization needs to achieve, which is pretty significant investments in IT, about $1 billion in our current IT platform, and probably another $1 billion over the next several years. making 2%, and to the degree that it's higher than that, which means we mispriced. I mean, we're not trying to be higher than that. But the fact of the matter is, because of the lower utilization this year, our prices were higher than we had anticipated they would be. And so we made the decision that if 2% is enough for us to live on, as a not-for-profit, we have a responsibility to give that back to the customers and or the community, and we did both. For customers, we gave back about $170 million for the 2010 period. That was last spring. And the balance in grants to ACOs, ACO infrastructure. And in 2011, for this year, our estimate is that we'll be giving about $295. We actually credited the December bills so it's roughly, for a family of four, about $600. And if you think about it, it's about 1 month's premium in most cases for individual and group subscribers. Again, we're not trying to do this, but we do think the commitment to a 2% profit going forward and getting costs down to, if you will, closer to CPI ought to be all of our goals. Finally, and just to wrap it up, I hear people talking about when the exchanges get here and all of the uncertainty that's behind that. We can't wait. The era is going to be, I think, perhaps between now and 2014, we will see that pent-up demand come back, perhaps with a vengeance. I don't know that. I think it'll probably come back more gradually, but it's possible people have deferred even expensive things that they will now start to get because they simply can't wait anymore. And so it will, in fact, I think, given the chart that I showed at the beginning of this presentation, will destroy the private market. There will not be a private market to the degree that our costs are going up at 10% and inflation is going up at 2%. We simply can't continue to do that. I mean, it's theoretically possible, but given the state of government, given the state of what consumers can afford, I think it's highly unlikely that a private system will continue to function in that way. I think together we've got to come up with solutions that are bold. That means taking risk. We took risk when we guaranteed CalPERS that we would come up with a 0% trend on that ACO that we put out there. But that's the kind of risk and challenge we should be taking. And for so long in this industry, and it's really unfortunate, I think, that it's very, very comfortable as a health plan to point out somebody else's reason for why the costs are going up, or have them point out why our profits are too high and that's why costs are going up, or my salary's too much and that's why costs are going up. The reality is costs are going up too much. They're going up way too much. And they don't have anything to do with my salary, and I would say they don't have that much to do with hospitals or physicians intentionally trying to drive costs up to the level that they are. It's in fact the lack of real collaboration, the lack of taking this agenda urgently and seriously that has put us in the position that we are in. If we want to have a private sector solution, and I personally believe that the private sector solution is essential, I do not believe a single payer system will control costs. I think it will adjust costs. I think it's easy to ratchet down on provider costs in a single payer system and have global budgets, but that won't control cost. That'll simply reduce what people earn and frankly force us to the lowest common denominator. If we want great medicine, if we want great health care, if we want great prevention and great quality of life, then I think the private sector really has an opportunity, it has the obligation, and I think we can do it, I think we must do it, and I think with the help of people like the people in this room, and I guarantee you our company as well as I suspect other health plans, we will do it. Thank you.